Please turn it on.
Well, good afternoon, everybody. I'm so glad you can make it. I know everybody's got busy schedules and it's kind of hard to take 90 minutes out of your day, but I guarantee I'll teach you something you didn't know. And if I don't, please make sure to tell me at the end so maybe we can add something to it, okay? So I'm going to start out with the basics. So this will be a class that's tested at the end. I do need you to be 80% proficient, so you need to answer 8 out of the 10 questions correctly at the end. If I'm a good enough teacher, you should have all the answers correct by the end. So let's go ahead and get started. This is called best dressed wounds, skin tears in the elderly. As we all know, what causes us the most paperwork?
Skin tears.
Skin tears, skin issues in general, but skin tears make up probably anywhere from 50 to 60% of all our skin issues in the building. And that is probably, when I put it all in paper form, going to amount to this much paperwork. You know, I can't really translate specifically because most of our stuff's electronic now, but when I was here and we were using paper, it was probably this much for one skin tear, and that's without complications. If you want to add complications, you got another set. So what do all nurses want to do? Avoid this. So hopefully by the end, we'll be able to limit that paperwork down just a little bit. So here we go. Our learning objectives for this class, by the end, I want you to be able to identify risks for skin tears. I want you to know how to classify skin tears. I want you to try to be able to pick appropriate treatments for skin tears, and also what types of prevention strategies we can use to prevent skin tears. I'm going to tell you there's a glitch in my technology. There's always one. This version of PowerPoint doesn't let you do any animation, so it's going to drop everything on there. I'll talk about it each one as they come up, but that's not ideally how I wanted it to go. So just so you know ahead of time. So skin tears. What is a skin tear? Breaking the skin. It's basically where the skin basically peels off any portion of the body. It can happen pretty much anywhere. It's usually, usually on elderly, you'll find it on the arms and the legs most commonly. So then what causes skin tears?
Friction.
Friction. What else? Trauma. Also, you got blunt force. Are skin tears preventable?
Yes.
Yes, they are. Not all of them are going to be preventable, but the majority of them can be prevented. And those are easier treatments if we do prevention from the get-go. So what kind of treatments do we use on skin tears? Anybody know? What's the most common one we use?
Steri strip.
Yes, it is. Any other things that we use? What do you use on a complicated skin tear?
A foam dressing.
Foam dressing. What other things do we use? What if it's bleeding a lot?
Gauze.
We can use gauze, or we can use impregnated alginates. They usually help to control the bleeding. So why is this topic important to us? I kind of touched on that a little bit. First thing is, nurses, we always want to avoid the paperwork. So paperwork is usually my number one reason. Number two reason is going to be, we want to make sure that our residents have, the least amount of problems as possible. Skin tears are painful, very painful. People think they're not just because it's just a slight rip in the skin, but it's really not. They are painful, and they can, continue on to get complications. So if we prevent them from the get-go, we can avoid our residents from having less pain. We can also avoid less trauma for them. So that would be the second fold reason why we want to avoid skin tears from the get-go. Okay. So understanding skin tears. There's an estimated 1.5 million skin tears in institutionalized older adults annually. That is a massive amount. Traumatic wounds, they're traumatic wounds that are caused by shear, so rubbing. They're caused by friction, rubbing. And they're also caused by blunt force, whacking into things. So they can, there's a misconception that they're only partial thickness, but they can actually be partial thickness and full thickness skin issues. So what happens with elderly people is there is a basement membrane between the dermis and the epidermis, and as they age, that tends to wear out. So then it won't be able to withstand the friction forces, and that's what causes it to tear. So here's some examples of skin tears. You can see they can start out just little ones like this. This is obviously a healed one, and then, you know, where most of the skin is missing. So interesting facts about skin tears you might not know. They have the potential to close by primary intention if we catch them early enough or they happen just right. That's usually, you know, surgical interventions. Anytime you have a surgery, that heals by primary intention, pulling the skins together and having it epithelialized right across that bridge. They're seen more frequently in women other than men. The reason I probably think more women have them than men is, especially in our types of facilities, long-term care facilities, women live longer. So they're more likely to sustain more of them throughout their lifetime. Often more in the Caucasian population. I speculate that probably has to do with the melanin production and maybe their sebum production. Hospital beds are the most common equipment-related cause for skin tears because they bump, we move them, we hit corners, that kind of thing, followed by the wheelchair. So the most common risk factor is actually just being old, advanced age. Because like I said before, you get that flattening out of that basement membrane, which means that it won't withstand friction or rubbing in any manner. Like we can just simply go like this. If you were to do that to an elderly person, you are going to rip their skin. There's a reason why, because we still have more elasticity in our skin, and as they age, that goes away. So it's just gonna rip right off the bat. Also, they have a decreased rate for wound repair and collagen production. Everything is slowing down. So every mechanism used to fix skin tears is no longer there, or no longer there in ample supply. Also, you have impaired vascularity. So most elderly people, all their blood vessels tend to come to the top of the surface because they're losing more of that basement membrane, so that could be an issue. They also have no fat, so there's no cushion anywhere. Nothing to help them withstand any pressure or blunt force trauma. Also, there's the thinning of the skin. So, you know, if it's thin, not thick, it's gonna rip easier, less layers. Also, they have reduced sweat gland secretion, which produces sebum, and what that does is it actually provides our own protective mechanism for withstanding skin issues. That's why you don't get rashes every time you touch chemicals and things like that, because you already have your own made protection system by sweating. So when that decreases, you lose that protection mechanism as well. Other risk factors, so people that are dependent on ADLs, they require more handling. Someone is going to touch them. When you transfer somebody, you're touching them. When you use a gait belt, you're touching them. When you get them into the bathroom. When there's more people in an activity and moving people around, we're not as cautious as we should be when we're moving people because it's not our arm that's getting whacked, it's theirs. And we don't realize that we're gonna hit it until we actually hit it. Impaired mobility and unsteady gait, what does that lead to? Falls. Usually if an elderly person falls, there is bound to be some damage. If they have a history of previous skin tears, any place that has repaired itself once is usually going to have a little less elasticity and a less chance of healing the next time. Poor nutritional status. So we know elderly people, they don't like to eat and they don't like to drink. So they're already in a malnourishment category, and without being properly hydrated, your skin can't perform the functions it's supposed to. Visual changes. Can't see anything, you're bound to run into things. So that can definitely cause issues. Sensory and cognitive deficits. If they're confused, that definitely make things more complicated. Maybe they don't know where they're going. They stumble on something. Things like that. Skin changes. So their skin is aging. It has lots of rapid changes. That definitely increases the risk factors. Incontinence. Any place that's got lots of moisture, so if they're incontinent of urine, going to create a moisture area that we need to really contain. Incontinent of BM. The acidity in BM and urine can literally peel the skin off, so we need to make sure that we're on top of incontinence care. Polypharmacy. If they're on lots of meds tend to have lots of effects on your systems, particularly the skin. The most common ones you're going to have problems with are steroids, like prednisone, Coumadin, so blood thinners. Those things definitely contribute to skin tears in this population. Heart, lung, and vascular disorders, because if those are not working, things are not going well in your body. If they're resistive or combative with tears, well then, you know, hitting around, kicking things, likely to get hurt. Also, we don't normally think about it, skin cleansers. If we aren't using the appropriate skin cleansers and they're not pH balanced, we could actually be doing more harm than good. Any questions? Okay,
Nope.
make sure to ask any questions as they come along. If I go too fast, please just let me know, okay? So what causes a skin tear? Transfers, like I said before, improper handling. Often you see staff jewelry and nails. We gotta be cautious with what we're wearing, you know, because we're touching and handling other people. Just because we don't think our ring is gonna catch somebody, it really could. Our nails, we gotta make sure we keep our nails short and make sure that they're not jagged. We're always worried about what our residents' nails look like. Well, we probably should check everybody's staff nails too, because they're not just caused by residents' own skin, nail to skin connection. So procedures, falls, that evidently if people fall, there's a likelihood there's gonna be some skin damage somewhere. Procedures, blood draws and such, putting an IV in, you have the potential to rip their skin doing that. By holding it taut and putting it in, we could definitely cause some skin issues there. Blunt trauma, bumping into things, that can cause skin tears. Wheelchair injuries, so maybe they have a sharp angle or something on the vinyl of their arm pad. If they catch that just right, you're gonna have a skin tear on the elbow. So we have to make sure that we're really looking at wheelchairs, making sure that there's no blunt, sharp objects that could hurt somebody. Removal of tape and dressings. Epidermal stripping is what happens when you take off dressings. We need to be very careful when we take dressings off, and we also have to make sure that everybody's aware of how you put the dressing on so that you know how to take it off when you have skin tears. Because if you pull a dressing off of a skin tear that's got a flap and you pull it in the opposite direction, you are now going to potentially rip that flap off. Then you're gonna have a way higher category skin tear than you had to begin with. Also, improper use of skin sealants. So it's not just slap some sort of cream on it, it's making sure you use the right cream at the right time, okay? So now we're gonna have our Be Gentle activity. So in front of you, you'll see a tomato, and you'll notice that it has some sort of adhesive product on it. What I want you to each do is try to peel it off the best you can and see, we're gonna see how different tapes react. The skin on this tomato is kind of the fragility of skin. I couldn't find super ripe ones, so I'm hoping it'll still work the way it's supposed to. But I want you to try and peel it off and see if you can get it off without causing any damage to the skin.
I think I just caused a skin tear.
So you can see how easily it would happen. I got some good tape. This one comes out pretty easy, so I didn't cause any. Good thing is we have a lot of different tapes here that we really did try to make sure that they don't cause a lot of damage. Adhesives should be we should try to avoid adhesives when you're dressing any type of skin issue, because they can cause epidermal stripping. Now notice I only had these on here for about an hour. The tape was only on here for an hour, but if you think 2 to 3 days, how stuck on is it gonna be? It's gonna
Especially with hairy arms, whiskers.
Yep, definitely. The other thing that we use here that is definitely a plus is we have that adhesive remover. You definitely want to use the adhesive remover, kind of catch underneath it, and then peel back slowly. Make sure you hold kind of taut at the end where you're pulling it off, and pull it off close to it so that you're only pulling off little centimeters at a time, so that it's not going to peel it. If you were to just rip it off, you are going to have a massive skin tear.
Now, if you did have a dressing over a skin tear and you were someone who hadn't seen that skin tear yet, is there a way to let people know that the flap is situated this way? Or
So the way you should do it,
how should it, yeah.
the way you should do it is actually put a directional arrow on how you want them to pull it from.
Okay.
So that you know, if your skin flap is pointing this way and
Right.
it will peel up this way, you would definitely want to peel downwards. So
Right.
your arrow would be downwards on the dressing. And we
Okay.
should be doing that every time, just to make sure that everybody knows what direction to pull
Right,
the dressing off.
right.
Do you recommend making the little tabs, like at the end, before putting tape on, so you're not
I never thought about that, but that would definitely work. The only issue I could see coming up with doing that is if you leave areas for them to pull it up,
They're
people
gonna
can get it.
Yeah.
But we could certainly try it. It's definitely a good idea, because, I mean, if you don't have to, because yeah, you could cause a skin tear by, taking your nail, just trying to peel that little piece off. So we could certainly try it and see how it goes. I mean, if they pick at it, then we'll know not to do that the next time, but
You might know who a picker is too, versus not a picker.
that is true. If you know your residents well enough, you kind of know what's gonna work for them and what's not. Okay, any questions about that activity? How did you guys do? Were most of you pretty good taking the tape off?
That was good.
Okay,
Perfect.
I didn't have super ripe tomatoes. When you have a super ripe tomato, it sometimes peels. But this really does kind of translate to skin. If you were to take a really ripe tomato and if you were to run your hand across it like this, you would definitely rip it. So I just didn't get the best tomatoes, but sorry it wasn't the best activity, but you get the general idea. Okay, moving on. So are all skin tears the same? Are any, I mean, some are similar, but are they all the same? Do we treat them all the same?
No.
No, we don't. So that leads me into how we determine what skin tear is which. So Peyton Martin there were a couple guys, they decided they were gonna, in the 80s, determine a common language. As we know, nursing's got all these different languages, you gotta be able to, decipher what's what. They wanted to make it universal so that everybody could tell that this one was this one and that this one was this one, based on characteristics, making it all universal and usable by everybody. So they divided skin tears into 3 categories. So category 1 is going to be a skin tear without any tissue loss. You can have a flap, but it can be fully approximated, so the edges can be moved directly to each other. There's no missing skin. A category 2 is a skin tear with partial skin loss. So you're going to remove some of the skin from the area. A category 3 is there is no skin left. Kind of like an abrasion, but an abrasion is caused kind of in a different manner. So this is going to be a complete skin loss. You have no skin to help you approximate or fix it. So category 1 skin tears. There's 2 subcategories. You have a 1A linear skin tear. That's going to be a direct lineal skin tear. It's a full thickness wound occurring in a wrinkle or a furrow. This is a classic linear skin tear. You've noticed that there's no skin missing anywhere, and this one could be easily approximated to here. So that one's a clear linear tear. These ones you also frequently see them in the brow, like blunt force trauma. Kids usually run into things, they're right at that level that when they run into a table. That's where you'll see those other linear tears. It's usually a blunt force to a general area that's going to cause a linear tear. What else would you get a linear thing? Surgical things would be linear. So, because you're cutting directly into it, and it's a clear line. So then you have a category 1B, which is going to be where it leaves a flap. The skin, this one kind of looks like it might have skin loss, but not a whole lot of skin loss. It might actually be rolled in here and they just haven't cleaned it up all the way. I couldn't be certain, it's not my picture. So what do you, it's a flap type area and it's a partial thickness wound, but you can approximate it with less than 1 millimeter of dermis exposed. So this area here. And I'm assuming that that's probably less than 1 centimeter if I were to actually look at the person. So then we have a category 2 skin tear. There's also 2 subcategories in this area. So you've got a 2A, which is scant tissue loss. So what that means is you're going to have less than 25% tissue loss and less than 75% of the dermis exposed. So this one right here is a scant tissue loss skin tear. So then you have a type 2B, which is moderate to large tissue loss. That means you're not going to lose all of it, but you're going to lose most of it. So it's a partial thickness wound with more than 25% of the flap lost. It either rolled under and it had to be cut off, or it got necrotic and it had to be cut off. We don't do any cutting. That will require some advanced personnel looking at it. But usually if it goes necrotic, they're going to have to cut it off, which would advance your stage in the skin tear. But you can see how this one is definitely not going to approximate and you're missing areas. So more than 25% of the dermis is exposed in this entire wound. And that's what a category 2s look like. So then you have a category 3, a partial thickness wound in which there's no epidermal flap. So there is no skin that is going to help us fix it. It is going to have to heal not by primary intention. So that would be how we're going to treat those. Any questions so far?
Nope.
So then I really liked this picture. It's based off the Payne Martin method of skin tear classification. So here's another picture kind of showing you the difference between the two. This one has a flap, but it's all the way down here, and I'm assuming that it can come up here because somebody else made this too. So This one, I'm assuming if it comes over, it's only gonna be to about here. This one, they're counting it as a 2 with large because you still have this little teeny piece of skin here. If this piece was gone or got necrotic and we had to take it off, it's gonna look like this, where there's no skin. So there's another comparison of what the 3 categories look like. So what are the goals of skincare treatment? Well, we need to stop bleeding. We definitely don't want them to bleed to death from a skincare. We need to maintain the integrity of the skin flap. If we want it to help us heal the wound, we have to make sure it doesn't die on us. So we need to act quickly, we need to clean quickly, we need to make sure that we try to preserve what's still there. If you wait too long, say someone told you about a skin tear but you were too busy doing something else to go check it out, in that hour that you took to get down there because it wasn't bleeding, the flap could go necrotic and now you can't use it to help you and now it's kind of a useless piece, it's kind of debris. We want to reapproximate the edges without undue stretching. The thing to really note is when you're fixing any skin tear, you do not want to stretch it because you're going to add increased tensile strength or increased tensility to it, and you're going to pull it. It's actually going to have to work harder to fix it. We want to promote moist wound healing. They've learned since, before you used to let wounds dry out. Now you need to make sure that they're moist so that the skin can move across the barrier. Also, we need to protect the wound and the surrounding skin from any further trauma, because if you have a skin tear here, all this area here is now vulnerable to something else happening. Also, we want to prevent infection, so we want to make sure we're cleaning it real well right away, because there's so many things that could get in it here. We want to make sure that we try and clean it as best as possible from the get-go, so we don't have those later complications. Because complications, they're definitely not good in any manner. We want to minimize pain. So when we're thinking about dressing changes and thinking about what we're going to do for our resident, how often are you going to have to remove that dressing? How painful is it for them while you're doing it? Are you going to have to pre-medicate them each time? We really need to make sure that we're making everything as smooth as possible for our residents, because we don't want them, as nurses, we definitely don't want them to suffer any more than they have to. Okay, then we want to promote comfort, so we want to make sure that it's most comfortable for them. If it's a dressing that causes them pain, just being on there, that's probably not the best option. Or we want to make sure that it's not causing them, maybe they're allergic to the adhesive or they're allergic to something that's in it. We want to make sure we take note of that right away, because you don't want them to be continually itching in an area that's already vulnerable. Also, we want to try to remove the cause. How did it happen? Is there any way to avoid that from occurring again? Which leads me to prevention of reoccurrence. What can we do so that this does not repeat itself? Okay, so treatment considerations. We must ask ourselves a few things while we're trying to figure out what kind of dressing we want to treat it with or what kind of skin tear we're dealing with. So first, what kind of category of skin tear are you dealing with? What type is it? Because there's going to be a different way to treat category 1s than category 3s. So we want to make sure we kind of know what type it is. Dimensions. How big is it? If it's a super big wound, we're going to really have to take that into consideration. What kind of dressing options do we have? If it's really small, that's going to be a whole different kind of dressing or treatment than a really big wound. Wound characteristics. So we want to make sure we take really good notes of what we got going on. What does the outer skin look like? Do we have viable or non-viable tissue in it? Do we know that this flap that's already necrotic is going to have to come off at some point? Type of an amount of exudate. Is it draining a lot? Is it super dry? That's definitely going to play a point in what we're going to do with it, because if it's super dry, we might have to add hydrogel, add something to promote moisture within the wound. If it's super wet, we're going to want to make sure that we have a dressing that's going to absorb that moisture, because otherwise we're going to macerate the skin around it. Again, that vulnerable skin right around the skin tear. We definitely want to avoid that. Again, looking at the surrounding skin. What are we going to do to make sure that we don't let that get worse and cause further damage to the outside of the tissue? Also, is there already signs and symptoms of infection? Maybe not when you first initially treat it, but maybe second, third, fourth dressing change. Does it have signs and symptoms of infection? Because if it does, you probably have to change your dressing to meet the needs of the wound. Also, how much pain? Is Is it causing more pain? Do they have to be pre-medicated? Do we need some sort of hydrogel or some sort of anesthetic put on it before we do it? All sorts of things that need to be taken into consideration if they're having pain. Any questions?
I have a question. What should we be using to clean skin tears with once they happen, when we initially?
So the standard is usually gonna be sterile saline, but there's all sorts of wound cleansers. It kind of depends on what our facility, formulary allows. When in doubt, always use normal saline because it doesn't have anything in it. We do have wound cleansers. McKesson makes wound cleansers and things like that, but still the gold standard for cleansing wounds is gonna be normal saline.
Okay, thank you.
You're welcome. So dressing options for skin tears. So we have a guideline for pretty much everything. There's a guideline for pressure ulcers, there's a guideline for bruise monitoring, there's a guideline for everything. However, there isn't when you come to skin tears. There is not a lot of literature out there that really tells you exactly what to use. So onto this paper tablet that I got for you. The paperclip stuff is all the stuff from this lecture, but behind it, the stuff that isn't paperclipped, is some of the most prevalent information that is out there, kind of distinguishing what types of cares could be and provided. The problem with wound care in its entirety is there is not a lot of research. So if we ever get into a point where we want to, do a research study, please let me know and maybe we can try and, figure out what works best for us. So there's only like 6 consensus research articles where they kind of come up with options that everybody's kind of agreeable with. Nobody's got a gold standard picked out, but these were the 3 most common ones that people reference. And then on the very back is our little reference table that tells you the risk factors you should consider when treating skin tears or assessing the risk for skin tears. Okay, so we want to determine our dressing option based on our wound assessment. What kind of wound characteristics and what kind of classification of skin tear is it? Those are important in determining what kind of options you have. We need to think about dressing changes as related to pain and skin integrity. We definitely don't want to be sticking a bunch of tape on somebody. That's probably not good if they have super fragile skin to begin with. You want to avoid hydrocolloid dressings such as Comfeel or Tegaderm, those clear plastic ones, mainly because they are super adhesive and they also occlude the dressing from air. It's not going to breathe. So if it is exudating or it has some sort of fluid building up underneath it, that can cause infection or cause maceration. It's definitely not good for a wound. So although there's lots of other types of dressings you can use for skin tears, those 2 are definitely out. Avoid tape at all possible, which is really hard to do because we're so used to, let's just tape it on. Well, really we need to be taking full advantage of elastic dressings. We need to take full advantage of, if you do gonna tape, we wanna tape as least as possible. We wanna use tape such as paper tape or tape that doesn't have as much adhesive or tape that's at least breathable. But if you can avoid tape, we want to avoid it as all possible. So maybe you want to put Curlex around it and tape on the Curlex. We just want to try to avoid tape because, as I said in the very beginning of this lecture, epidermal stripping is what causes a lot of skin tears. So we might be treating a pressure ulcer and we're taping that pressure ulcer dressing on there and then we're ripping it off. So we might cause secondary skin tears to other wounds if we're not paying close attention to dressings. Also, you want to mark dressings with an arrow to indicate the direction of removal. Work away from the attached skin flap. So we want to move with it. We don't want it to move back and peel at us. So we really, to best dress our wounds, we want to make sure that we're making sure that everybody else that follows behind us knows what we're doing. So mark your dressings accordingly. So category 1, skin tears. You got a couple different options. Skin closure strips, as we all know, steri strips. These are the most commonly used, and that's because they're cheap. They do work, but the problems with these is they're very often applied in the wrong manner. So if you apply them the wrong way, they're not going to work. Also, you have wound glue, which is going to be Lipoband. This is super cool stuff. They use it in surgery, and I did finally get them to approve us to use it here. If I promised I would teach you how to use it. So today we're going to get to use it and see kind of how it works. It's kind of, the downfall of this is it's kind of expensive. So luckily, there's a few amount, but I only have 3 when we do go to practice them. So there's quite a bit in here, so I just want everybody to kind of get a feel of what it is to use it, okay? And if you don't get a real good feel, the next time we have one that we can use, please come find me and I'll let you do it, okay? The problem with these is these only amount to 20% of our skin tears. So there is very limited amount that these are actually good for. So then you got category 2 and category 3. So we got lots of dressing options. This is where your wound assessment is really gonna play a part into it, because what do we need the dressing to do? So you have lots of different things that we can use here. So first thing it talks about is Caro gauze or Caro alginate. These are going to be calcium alginates. These help to stop bleeding. So if our wound is bleeding a whole bunch, these might be a good option. Depends. This one doesn't have any moisture to it, so if we want it to suck it all up, this might be good. If it's scant drainage, but it's definitely bleeding, maybe we need an impregnated one. This one's moist, really moist. Then you have soft silicone dressings, which I would have to say this is probably our best treatment option, is gonna be Mepilex. It's like a soft silicone. It's mesh. This does not have to be changed every single time, but it will maintain the integrity of your flap. It'll hold it down while you change the secondary dressing on top of it.
Just like a contact layer?
Yes, contact layer. And they now are making biotin silicone ones, so these ones have similar properties. They're not exactly the same because these ones have to be removed, but their silicone is definitely one of those things that peels off your skin really easily and doesn't leave any residue. So that's why these are really good options, and you'll see them most often.
Can the drainage help do that dressing?
Yes, yes it can. It's like a mesh it's got little holes in it, and as it kind of looks meshes, so it allows it to breathe, and it allows you to put a secondary dressing over the top of it, and the exudate will be sucked up into whatever your secondary dressing is. And we'll get to play with those in a little later. So then you also have foam, which I kind of said before, with biotin foam. That's going to have a layer that allows the exudate to be sucked up into it, so that we're not creating more moisture on a wound, because we know what happens with more moisture on a wound. The likelihood of infection is going to be higher. Okay, so then we also have hydrofiber dressings. Those are really cool. If you have a wound that is exudating a lot, a hydrofiber dressing might be your option, because they have some dressings that'll hold like anywhere from 120 cc's to 350 cc's. That is a lot. I mean, that's a good glass full of fluid. And if you don't have to change, if it'll suck up that much, maybe you won't have to change your dressing as often, which would be better for a resident. Then you have hydrogels, things like, here's a couple examples of different hydrogels. This one is just basic hydrogel. It's just going to add moisture to the room. It doesn't have an active ingredient. It's just going to provide moisture. Then we have an anti-type infective antimicrobial option. So you have hydrogel with silver in it, going to help decrease the bioburden in the wound. And then you also have this really cool new product called TheraHoney. There's different versions. It all depends on what your formulary will allow. Ours allows TheraHoney. There is another one called MetaHoney. You can get impregnated gauze. You can get impregnated foams. So we can find lots of dressings that have hydrogel properties to them if our wound needs moisture. So that's the options we have there. Antimicrobial dressings. Anything that's got silver is an antimicrobial dressing. The other cool thing about that Liquiband, this also has antimicrobial properties to it. So that's kind of, our dressing options. There's lots of dressing options. You just want to make sure that when you're dressing a wound, you're dressing it to the characteristics and the needs of that wound. So there's definitely a wrong dressing to put on wounds, but there's definitely some options within a given category that you can pick a few. Okay, so the treatment of category 1 skin tears. We kind of talked about traditional steri strips. See how that's a straight lineal tear? It has to be completely approximatable. These ones, when you use Liquiband or steri strips, you cannot really have much skin loss. They have to be fully approximatable. You're going to want to avoid joints. Anything that is high tensile movement is not going to be a good place. So your elbows, your hands, your feet, definitely not going to be good options for either one of these. But if you get one here, get one here, get one here, those might work well. So kind of make sure you take that into consideration. What is the location or anatomical position of your wound. So I'm going to try to show you the difference. There's really not a lot of literature to determine which one of these works best. There's definitely some pros and cons to both of them, so I'm going to kind of give you a snapshot of what kind of characteristics we have for each one. This table here was taken from a study done in the surgical area, so this, not necessarily all this will apply, and I did give you guys a copy for your further reference should you need to look at them. So what I could figure out is we're going to use skin steri strips or wound glue for short linear, low tension wounds that are less than 5 centimeters in length. So they need to be pretty small. We need to avoid the hands, the feet, and moist areas. They do work for groin areas dependent on how much moisture is in that area. So if it's someone that's really, really sweaty in their groin, probably not going to be a good option. Why? Because both of these are going to come off. They're not going to be a real good option. The pros to steri strips is they're affordable and they're very widely used. Everybody learned somewhere along the line how to use a steri strip. The cons, they often fall off before the wound is healed, and they are often a source for residents to pick at them. They get bored or it starts to peel up a little, they're like, oh, I'm going to pick it off. Kind of like picking scabs. Do not pick your scabs either, that's a bad idea. Often requires a secondary dressing, which in turn means you can't get it wet. So showering is kind of out the window, which kind of decreases the comfort for a resident. I mean, if you're icky and gross, I mean, that's not very cool. So then, we got skin adhesives, so kind of a snapshot on what these are. So the pros that I found with this is there's no secondary dressing required. So if it's not oozing, it doesn't have a lot of exudate, we can probably just glue it. The other thing is it's waterproof. So they can, within 24 hours, they can shower. Now they can't take, a hot tub bath or anything, but they will be able to shower. That is always a plus for residents. People like to be clean. Also, it's got usually a faster repair time because it automatically seals it. So then it gives it time to work, the skin underneath, to move across and repair itself. It's got antimicrobial properties, which steri strips do not. These are simply an adhesive paper tape that holds them together. It's pretty easy to use. The misconception is that this actually goes in the wound. It does not go in the wound. When you approximate the edges, you are actually just providing it a bridge. So you're actually just putting glue over the area to hold them together. It's not going in the wound at all. Hence, the reason why your wound has to be linear and has to be able to be approximated, because this is really not supposed to go in your wounds.
You gotta hold it for a certain length of time.
You'll hold it for 60 seconds. You have to hold it in that area for 60 seconds. And I'll show you how to use these, and then I'll get you guys a little bit of experience with using them too. It's always cool to use new things. Cons, these are more expensive. These cost us like 30 cents. These cost us $16. However, if you can get it to heal the first time and we don't have to reapply any secondary dressings after these, might be a better option. It might actually be money saving if we only have to use one treatment. So also, like I said before, there's only a small number of skin tears that actually can use either of these options. Other things that you should know about contraindications for using these, if they're infected. If it's already an infected wound, we are not putting these on there. We do not want it to get an abscess and dehiss and all that good stuff. Nope, bad idea. If there's lots of copious bleeding, these are not going to work. If they're in areas of high tension, so like those joint areas, it's definitely not going to work real well on a knee, unless they're completely immobile. You can use it on high tension areas, but you are going to have to immobilize the source. Well, you know what that means for us? Restraint. We're staying away from that. Also, if they have lots of fluid or edema around the area, this might not work either because you know that it could possibly start to leak, and that could cause problems. Animal bites and burns, definitely don't want to use those. They are high sources of infection and usually require multiple dressing changes. These, we usually want them as a one-time shot. You might reapply steri strips the second time around if it didn't work, but usually these are a one-time deal. We're hoping that after 7 to 10 days, it's got a pretty good skin hold and it's going to heal from there. Also, you don't want to use it on mucosal surfaces. We're definitely not going to use it in your mouth or your eyeball. And then areas with high moisture or really dense hair. If they are super, super hairy, that might not be our best option because it might actually impede where you're gonna be able to put it. And you know, some people might be okay with you shaving their chest hair, but some people are probably gonna have a problem. Any questions on the differences between the two? They're pretty similar in what they do, it's just a matter of what our preference is and how we think we can best heal the wound. Like, if the wound really would do better with steri strips, we should use steri strips, even though we think this is way cooler to use. So, kind of take that into consideration, like what is best for our resident and what is best for the wound. Okay, so now I'm going to show you how we apply steri strips, how you do it the right way. So what I'm going to do first is we're going to go over exactly how this says here. So I would have washed my hands, put my gloves on. You always want gloves on when you deal with wounds. You know, definitely don't want contamination. You definitely don't want bloodborne pathogens either. So always make sure you're sanitary. You want to keep wounds as clean as possible. Most dressing changes aren't sterile unless specified to be sterile, but we want to make sure that we're paying attention. So on this orange here, I have a linear tear, straight linear. It will approximate itself.
So do you recommend eye coverage?
Eye coverage. If you were going to use Dermabond on the eye, you
No,
would.
I mean as far as protecting yourself.
If you think it's going to splash up, if you're using, if there's lots of liquid, or you're going to get right up in it, and it could potentially splash in your eyes, I definitely would. I think about it a little less than most people because I have glasses, so I already have that first protective mechanism. But if you think, I mean, always err on the side of caution. I mean, you don't want to ask for forgiveness later in that manner because it's definitely not got the best outcome. So, what we're gonna do, well, I shouldn't do it there. Electrical problem. First thing you want to do is you want to make sure you thoroughly clean the wound. We want to make sure that there is no areas that they are going that have debris or something underneath them. So we got this linear skin tear. I'm going to clean it as it says. Gently clean the wound. You don't want to be super forceful because too much pressure, you can actually cause damage to the tissue. Apparently at one time they used to use those, before anybody knew what kind of PSI you should be using, they used those dental cleaners. And that is super high PSI. They're going to rip skin, tissue underneath it. These ones are appropriate for most skin cleansing. We also have a few sprays that are actually specific to which PSI they'll blow out. And we want to stay within that 4 to 8 range. If you have any questions on what's what, please come talk to me and I'll let you know, okay? But these are the most common for us. So we're just going to kind of gently cleanse the wound. Make sure we're getting anything underneath it. If we had a flap that could be approximated, we'd really want to moisten one of these and roll it under so that we're pulling the skin back out. You don't want to pull real hard, but want to pull enough that we don't have anything that's curled under. Because if it curls under, it's not going to get adequate nutrients and then it's going to go necrotic. So we're going to roll all of this over. Then roll it back, utilize moistening skin tipped or cotton tipped applicator. Lay the skin flat over. We don't want to overstretch it, but we want to make sure that it is going to reach, that we don't have any tissue loss. So we're going to approximate the edges. As close as possible. Again, do not stretch super hard. Steri strips have this fancy little convenient thing here so that they're easy to pull. You can use forceps or whatever. These are pretty long, so I think I'm going to be able to do it. So I'm going to close this. You want to start in the middle of your wound. So start here, hold it, and then pull here. But don't stretch too hard. See how we've now actually closed it? Now what we want to do is, we start out in the very middle. The reason why is because then you decrease the tension load. That's usually where the most pull is going to come from, is the middle of your wound. So now what we're going to do is we're going to place subsequent strips about 1/8 of an inch next to it. And you also don't want to run your finger across the middle of the wound, because you only want to secure it here and here, and then you can run these here. This will automatically, if you've done it correctly, should seal down. Okay, so that's what it should kind of look like. If we think that it's, causing some stretching, we could add what they call a railroad strap to kind of take the load of the tension, which is where you're going to put them next to it, and you'll put another one right here, and it would cause a railroad, which what happens is that it decreases the tensile strength within the middle of your wound. It's kind of holding it here. So if you think that it's going to pull or it has a chance to dehiss, always railroad strip the sides. Any questions on how to do that? So that's how you do it with a steri strip. So now I'm going to show you how to use the wound glue. So first thing, we got it in our package here. We clean the wound like we did with the first one. So I'm going to clean it all out. Make sure I've pulled my skin flaps out. This one's got a pretty good skin flap, but it looks like it will approximate. Pat it dry. You want to make sure that when you're using steri strips or when you're using a liquid adhesive, that everything is dry. Because if it's wet underneath it, it is not going to hold very well for you. And then it's just going to come off.
Can you skin prep the area over the top of the reapproximating skincare?
You shouldn't. Research says that you shouldn't. You probably could if you were doing dressings, like if you were going to have dressings and you wanted to protect the area. But specifically for glue and steri strips, they could have a property in them that could break down the adhesive. So then that would defeat your purpose as well. So typically not when you're using these two options. Now if you're using a dressing option and we're worried about all that vulnerable skin around the dressing, I would definitely use it there. So we're going to get this cleaned real well. Looks like I can approximate it here. So we're going to open this. These are really easy to use. What you want to be careful is that we're not putting too much glue in the area. If it happens to be on the eyebrow, you're definitely going to want to put like a petroleum barrier on the lid so that if it did fall down, hopefully it gets caught in the petroleum barrier. But you also want them to hold a piece of gauze there. I didn't read super far into the research, but it is going to take lots of ophthalmic drops and good stuff to get it out of there. So if at all possible, avoid those. The other thing is you want it laid horizontal out so that you're not dripping back. So if you were doing a wound on their face, you would probably want them laid down so it doesn't drip in areas that you don't want it to go. So that you also don't want to press really hard with these because it will leak a lot out. And there's quite a bit in here. It doesn't seem like it's a lot, but it shouldn't take you, if you're dealing with wounds that are 5 centimeters in length, this is quite a bit of stuff for a 5 centimeter wound.
Is that a single use?
These are single use. Once we break it, we're going to use it, and then it's going to be garbage. Okay, so we're going to open the package, holding it upright like this. You're going to squeeze the applicator wings. It's got these side little things, and you're going to hear like a crack. It's like it's busting a vacuole in there, and you'll see it change color. So then you want to invert it, invert the tip, and gently squeeze the wings. So these are purple, and I think they made it purple just to make it with ease of application. So now we've got purple in our foam pad here. So we want to make sure this is thoroughly clean and that it's dry, because once we start, there's no going back. So while holding the wound edges together, so we're going to hold them. Remember, not to stretch, but hold them so that you've got a clear bridge. Like I said before, this is not going in the wound. It is actually going to perform a protective bridge between one layer of skin to the next. So now what we're going to do, you make sure it's dry, we're going to hold the wound edges together, and now we're going to try to apply it as evenly as possible. And it'll go on kind of clear. And you want to do this 3 times. Also make sure that you're not running. So now what we'll do is we'll continue to hold this closed for 60 seconds for it to fully adhere itself. And now we have created a waterproof barrier and we have sealed the wound off. So that wasn't a super big skin tear, but I still have quite a bit left in here. So you definitely have adequate amount of glue, and that's probably where people have a problem is they think they have to use it all. Only use enough to make it closed. So So we're just gonna give this a few seconds here. I'll pass this around if you guys kinda wanna look at what it looks like before we get to it. The other really up and coming dressing that I didn't get to really look into, they have what's called a clear acrylic dressing, and that seems to be the up and coming one. I didn't look into it because it's not on our formulary because it's super expensive, but you can use it for all of them. So maybe the next time we have to do one of these, maybe we can talk about those. Because those seem to be really good. I didn't do super lot of research because I was focused on the stuff that we could actually do here. Because I don't really want to teach you things you're not going to be able to use. That really doesn't do anybody any good. So, still taking a little time. Thought maybe it takes longer, or maybe it's because this is a really cool, kind of cold orange.
What brand that acrylic dressing is?
It is a 3M.
Yeah.
3M. Look into it.
Well,
It looks super cool. That's what happens when you become a wound care nurse. Dressings are super cool. We want to try all the new ones, especially when we can do it on company money. So again, we just want to maintain that we're not, if we let go before it has actually adhered, the application is going to be worthless to us. So now I'm going to pass this around. I think it's almost dry, and it'll kind of show you what it looked like. And it might work on a different fruit slightly better, but I wanted to have one that we could really kind of get the skin and try and figure out what it looks like. Any other questions on skin glue?
So we would use these for both types of category 1 skin tears.
Yes, you could. As long as there's no tissue loss and that the edges can be approximated, you can use either one.
Okay.
But again, we want to think about our resident. What's going to be best for our resident? Like if they're going to pick at steri strips, maybe glue is the way to go. If they're not going to pick at them, and or maybe they're super conscious about what they're paying for here. Like you get those people that are like, oh my God, don't use that because it costs too much money. We definitely wouldn't go with the glue. So we just kind of got to look at the wound characteristics and then take into consideration our resident to try and really figure out which one is the best option for them. Because although we have this fancy wound glue, we don't need to use it all the time. Again, kind of spendy. But in wounds that wound that you get above your eyebrow, I would definitely want it glued because steri strips are not going to hold super well. And you also aren't going to want to go to public with, 8 steri strips on your eye. People usually are a little self-conscious about that. So, you really kind of got to determine what is going to be best suited for a resident and for us. Okay, so moving on. Treatments for category 2 and 3 skin tears. They're pretty similar because there's tissue loss. So when we have tissue loss, we're going to look at the wound assessment. Help us indicate what kind of dressings might be best suited. So you got those contact layers. If we just need to secure the flap, that's a really good option. I foresee us using contact layers most frequently. You have soft foam dressings. If there's lots of exudate or dressings, or exudate or bleeding, foam dressings might be a good option. Some of these can be used as primary and secondary dressings. You can use combinations. It's just a matter of what your wound looks like, what your wound needs, okay? So you got alginates. Alginates have, a polymer in them that help control bleeding. So if they have lots of bleeding to a wound, or one of those category 3s that has no skin to help anything, those ones are usually going to bleed because the whole area of the skin is exposed. All the vascularity is exposed. So if we need bleeding controlled, alginates might be the way to go. If it's already infected, you're definitely going to want an antimicrobial dressing. We want to decrease the bioburden as quickly and as soon as possible because infections, what do they do for us? They increase that paperwork, they increase the pain for our resident, and they also can cause further complications. Like if we let it get completely infected, maybe they're going to lose a limb, or maybe they're going to lose a toe. And we definitely don't want to be responsible for that. So we really need to make sure we're on top of any type of infection. So anything that's got silver in it, something antimicrobial, just try to avoid infection as much as possible. The minute you see signs and symptoms of infection, going to want to let the doc know. Maybe we need a new dressing, that kind of thing. Hydrogels. We want to provide a moist wound environment. Study after study after study says you need to provide moist wound healing. We actually are not supposed to let things scab over anymore. Everybody's like, oh, if it's scabbed, leave it open to air. No, that's not the gold standard for wound care now. Moist is the way to go. Keep it moist until it's healed. And also, when you add moisture to it, it also relieves pain, because if you think about it, if it's drying out and it's pulling apart, everything is stretching, causing weight, and it's, you know, your nerve endings might be exposed or things like that. That could cause a lot of pain, hence the reason why you really want to put some moist wound gel in there. So, throw this away here and clean my mess a little bit. Any questions?
So what if you notice the skin tear does start to kind of form scabby? Is you just let it do its
It
thing?
can kind of form scabbing, but you're still going to want to add moisture, because once it starts to scab and parts of it are still open, it's now drying out, which means you might end up with a scar. That's that's how you end up with more scars, is they scab over, they get dry, that kind of thing. So cosmetically, we really want to keep them moist as well.
The more you pick and scab, the longer it takes.
Yep, that's why you don't pick at your scabs. The other reason you don't pick at your scabs, you know how much gross stuff's under your fingernails? Gross! You could easily become infected. That's why they say scratching is bad. That's why cat wounds are always bad, because they're, you know, digging in their cat litter. Gross. Gross. Okay, so contact layers. I am really passionate about this Mepitel 1 because I really think it'll do lots of good things for us. It decreases dressing change times. It helps secure that flap. It can be used as a primary dressing if there's not a lot of exudate. It can be used with a secondary dressing if we do need to manage exudate. It can be used under a secondary dressing. It can be used under compression stockings. It also can be used with wound vacs. So maybe it could be that kind of layer that they put on top of the tendon, depending on how much pressure you're using and things like that. There's less damage to the skin flap in the surrounding area because you're basically covering the whole area of problem with this silicone mesh layer. So, and it doesn't have to be changed frequently, and it allows for less disruption of the skin tissue. Because most often what happens for us is we go in there and rip a bandage off, and then we've caused more damage. So any healing that has happened up to that time, you have just taken it off. So this really helps with that. So I got a little short video from the Mepitel company that kind of tells you a little bit more about them.
Monica Healthcare offers a new wound contact layer dressing that provides undisturbed wound healing and minimizes trauma to the wound and pain to the patient upon removal. This is the new Mepitel 1. Mepitel 1
This is on our
designed for
formulary.
a wide range of wounds, such as painful skin tears, abrasions, surgical
And
incisions,
multiple uses.
partial thickness burns, traumatic wounds, blistering, lacerations, partial and full thickness grafts, radiation skin reactions, and leg and foot ulcers. It can also be used as a protective layer on non-exuding wounds and on areas with fragile skin. Mepitel 1 can be left in place for up to 14 days, depending on the condition of the wound, which reduces the necessity
Which we know,
of frequent primary
skin
dressing
usually
changes.
tries to heal itself within
The
7 to 10
porous
days, so
structure
that's
of
really
Mepitel
cool.
1 allows exudate to pass into an outer absorbent dressing. The SafeTac layer is on the wound contact side only. It prevents the outer dressing from sticking to the wound and ensures atraumatic dressing changes. The SafeTac layer also seals around the wound edges, preventing the exudate from leaking into the surrounding skin
Now what kind of
and
wound is
thus
that?
minimizes the risk of maceration. In addition, Mepitel 1 does not leave residue on the skin or in the wound bed, and it conforms well to most body contours. Mepitel 1 is transparent for easy wound inspection during application and wear, and provides a low potential for skin irritation and allergy. To apply Mepitel 1, clean the wound area and ensure peri-wound skin is dry. Remove one side of the release film and apply Mepitel 1 to the wound. Then remove second release film. Allow for at least 1 centimeter overlap of wound edges. Larger wounds may require more overlap. Apply an outer absorbent dressing and a retention dressing if needed.
See, no tape.
The absorbent dressing may be changed as needed, but Mepitel 1 may stay in place as recommended by the clinician up to 14 days. Mepitel 1, the newest addition to the Monica Healthcare family of SafeTac products. The right and best choice for minimizing trauma and pain to the patient during dressing changes.
multiple sizes, so we utilize 2 different sizes here. So, in addition to that, they also have this version, which is a Mepilex transfer, which has that mesh on the bottom and a foam layer to help with it. So this one is a good option as well. It's kind of an all-in-one. You might have to put a secondary dressing depending on the exudate, but this one can be cut to shape, be cut to size, and it's kind of got both properties that you might need. You know, not that traditional foam dressing. Okay, any questions? So then, what other options do we have? We also have alginates, foams, and hydrogels. I kind of showed you some examples of those earlier. Again, it's all going to come down to what your wound looks like and what your wound calls for. What kind of dressing are we going to need? So, what type of skin tear is it and where? How much exudate is there? What does the wound bed appear? How does it appear? Is there any infection? Is there any necrotic tissue? Is there anything in there? Does it need to be debrided? You might want to know that before you slap a dressing on the top of it. How often do you need to change the dressing? That definitely plays into it because we want to promote less trauma to the wound. So if you have to have repetitive dressings that have to be changed every single day, that's probably not super appropriate for the elderly. Maybe one of us, that would be fine. We could probably change it every day because we don't have that vulnerable skin. I mean, we have vulnerable skin around an area, but it's not going to rip like theirs is going to, for numerous reasons. Doesn't have signs and symptoms of infection. So we really kind of just, it all should be focused on your wound assessment. When you are assessing a wound, we want to make sure we get the best amount and the most accurate information because that is going to help us appropriately pick a dressing for it. So now we're up to our group activity. You guys ready to have some fun and try it yourselves? So what I want you to do is to split up into either 2 or 3 groups. I didn't have as big a turnout as I thought, so why don't we split into 2 groups? And then I'll have you each pick out. So with this group activity, so you know that there's a quiz at the end, right? So that I can make sure you're competent and able to do this at the end. The group activity adds to the points. So on my point system, you will get you can get up to an additional 3 points if you pick the right dressing, pick the right category of skin tear, and if you work well together, I'll give you 3 points. So allows you to miss more on your test, or allows you to do, exceptionally well. So go ahead and pass this around, and each of you take an orange. It doesn't matter which one you take. So you can take 1 or 2 oranges. It doesn't matter to me which one you take. And then this is what you have in your capability of what you want to use. Go ahead and use whatever you want in there. Kind of take a good gander at your orange and see what kind of problem there is to it. So go ahead and take an orange and pass it around. Oh, well no, pass
With
the
the
tray.
tray.
Pass the tray around. And since they only have 2 groups, I'm kind of going to throw some extra stuff in your bags. Just 1 group, you just need 1. And then you guys have your bags of supplies, which are in this one. There's your bags of supplies. Kind of go over and see what you got going on. And I'll dress mine from over here. I'm going to pick this full thickness one.
So that looks like only we could do blue or string strips.
Yeah, just dump it all out. We'll clean it up later. And then I did give you a towel so that if anything drains off, you can use that for it.
So we do have the skin glue, we're going to string strips. What? Sounds good to me.
The other thing is if you are going to use the glue and several of you want to try it, go ahead and grab another orange so that all of you guys can kind of see what it takes to.
Oh, this one has another
Oh, there's
similar.
That's what
Okay.
string strips.
We can make another one here.
Yeah.
Alright. You want us to clean first?
Yeah, do exactly what you would do.
Cleaning hands.
Yeah, we wash hands.
Thank you, gloves.
Already washed my hands.
didn't see it here.
Luckily, it's not bleeding very much, so.
It's always good when they don't bleed very much.
This person's not on Coumadin, so we're good.
Why would be here?
It probably did. We will not be eating these when we're done.
No, I just don't know. Cleaning up. You want us to give you a lowdown?
What do you got? What do you got going on there? So what kind of wound do you guys
I
have?
would say it's a stage 1.
That is
Yeah.
correct. What are you gonna use to treat it?
Steri strip. We were gonna do steri strip.
Okay, perfect.
Because it's not on the elbow
No, it isn't.
or a knee.
Good deal.
Yes.
Maybe the former.
This is a forearm, it'll say.
What do you guys got going on?
We both have category 1A, right?
Straight linear tears, cool.
Yeah, so we were going to try the wound coil.
Sweet.
Why don't you go first?
And I have the full thickness one, so I'm gonna dress mine too, and you guys can kind of look and see if I did a good job.
Are you going to use that?
So what I'm gonna do is clean it, I'm gonna use a Mepitel, and then I'm gonna use a silicone foam over the top. I'm doing okay. Over your 60 seconds. So go over the area 3 times, so make sure you hold it together. Because you want to make sure it's completely approximate. Remember, we don't want any of that to go in the wound. So we want to make sure that we're only causing, like, we're putting a waterproof barrier bridge.
So it doesn't go on purple.
No, it actually goes on clear. I think it's just purple to let you know that it's in the applicator.
Oh,
Really?
now I can see it's a little.
I mean, it's a little tinted, but that actually, you know, it's kind of like that purple drying kids glue. You know, it comes out purple, but dries clear.
Yeah.
I know what you're saying.
Alright. We'll let you guys use some hard glue.
But we could do half steri strips, half glue, just change it up.
They actually
would
say you
never-
can use them in combination with each other. So like in surgical repairs, they do both. They put the steri strips and then they glue straight across the top of it. So.
So it's kind of like a double
Yeah.
security.
And usually they do that in places where they don't really want to use sutures because sutures take a longer healing time and usually have more cosmetic declines to it. So
Yeah.
sometimes they do it in those areas.
You guys want to try this on yours?
Sure, why not? We'll do
Yeah.
half and half.
I'm glad you guys are so helpful to each
We're
other.
sharing.
I don't want to waste it. It's $16.
No, we definitely don't want to waste it, which is why, you know, we really should think about why we want to use it.
Can't
And
go under the skin.
it doesn't want to go under
You
the
gotta hold it
skin.
in place. Oh, it doesn't go under the skin?
No, you actually, remember, we're doing the bridge.
So back and forth 3 times. Is that what you said?
If you want to go across
So-
the,
That'd be 1, 2, 3.
I mean, up and down too? Or does it matter?
It
Which
was-
direction you go?
Emily, was it just along the line?
so you want to go along the line of the tear.
So the
The length of the tear.
Okay.
With the tear, yep, because we're basically just going to put this little invisible bridge.
And it doesn't stick to your gloves if you're kind of holding it in
It
place?
shouldn't, and if it does, it should come up relatively easily.
That could be a problem.
You're holding it down and all of a sudden it's up. I'll just remove my glove. Here you go. We'll just leave the glove attached.
It didn't.
Just take
It
off
did
the
it.
finger.
It's not,
it'll work.
yeah.
So in a case like this, if you weren't real sure about the glue, could you put strips over top too after
You
it
could,
dries?
yes, you could. You could,
Could you do that for an elbow or something?
Like do a double.
Yeah, would that maybe
you probably shouldn't use it on an elbow because you're gonna continue
The
moving.
traffic's still.
So
gonna do
you're
that.
gonna, you decrease
Even
the
with
strength of
elbow.
it
It's so
every time you
pretty.
move your elbow.
This one's
Very
getting
nice.
close to the wrist joint, maybe we need to double up on it.
Or you would put those railroad strips on the sides
Oh, yeah.
because it would decrease the surface tension.
That looks more like.
How'd it work for you?
There's a tiny little gap, but I wonder if it's because the orange wants to open.
Wants to
So
open.
this is a high pressure area, maybe we
Yeah,
should
start
have.
Maybe because it's rounded.
Yeah.
That's what I'm
Or
thinking.
because I probably made the wound a little too big. So if you think about it, maybe I just did a smaller cut, but I had a really big knife from the kitchen. So it was kind of an all or nothing deal. So if it had been slightly smaller, it probably wouldn't push as well.
So
Yeah.
on yours, I didn't watch you do it. Did you do the?
Okay, so what I
Mepitone?
did is I did a Mepitone. The good thing about silicone dressings is they come off really easy, and usually you can peel them apart. So what I did is I cleaned the wound, and then I put this over it.
Okay.
So if you want to pass it around, go ahead and
Yeah.
see what it looks like. It kind of just, protects it so that as I pull this up, I'm not going to pull up any of the skin around it, and I'm actually going to leave that in there. Unless I see
So you
signs
don't
or
want
symptoms
this
of
touching
infection.
the wound bed?
It actually can go directly on the wound bed.
Okay.
So, but it doesn't stick to it. So you
Okay.
see how it kind of lifts up a
Right.
little bit?
Yeah.
It's because it doesn't actually stick to it. But like, see, if we were to
Squeeze
really
it
squeeze it out and see what happens is it will suck it up into here
Oh, I see. what
as you
okay.
have it on there. So then this will keep it so that it's, still moist but not collecting fluid underneath it.
And then probably depending on how much drainage there is, that could stay on.
This one can stay on until, unless, like, if you get signs or symptoms of infection in there, we're gonna wanna take it out, clean it real good. So again, the reason why these are super good is because we can visually see it all, right?
Right.
I mean, so we can, every time we could change this dressing every single day. Because this is gonna hold my flap down. I can take a good look at it, take this off, change it, put a new one. But this one, can stay anywhere from 4 to 14 days. And we know that skin tries to heal itself within a 7 to 10 day time frame. This would be really good to use, because it'll hold the flap integrity. It'll allow the moisture to be seeped into here, and it also allows it to breathe. So go ahead and pass it around, just kind of see what it looks like.
So if you were cleaning that, you would just put some saline.
And then pat it dry,
Pat it
just
dry
like it
through
was
it.
skin there, yep.
Yeah.
So yeah, you can still clean the wound and things like that. So it's a really good option, and I foresee us using it on lots and lots of things.
So we would go we would put the saline on to clean it with that still intact.
Yeah, because it'll still allow it to
And
go
then
in there,
use
but then
the
it'll allow
gauze,
you to seep it
Pat
through.
it dry,
Take a
and
good look
then-
at it, make sure it's what you want.
put a new dressing on top.
Yep.
Alright.
And therefore we maintain the integrity, so we're not ripping stuff off of it,
Right. But you wouldn't-
Where you would really have to pay attention is you would want to make sure that as it starts to close, that the skin tissue doesn't start to seep through those holes. That would tell you we probably need to take it off. So if you guys want to, I'll go ahead and hold the garbage out. If you want to go ahead and throw your garbage in here. If you want to keep your souvenir, you can, or we can just set these back here.
Oh, we still need the onions. right?
Yes, we're gonna get to that. That's my next part. And then if you wanna just throw all the extra supplies that we didn't use into whichever bag, that's fine with me. I'll be returning it to Central Supply if we didn't use it.
You should put like
Those, so what these were in there for is say I wanted to not use that silicone dressing. On my orange, if I were to, or we'll just say it's this one. Say I put my Mepitone on there and then I put an absorbent gauze. I then, to avoid tape, maybe I would put this around here. Granted, it would be stretchier, because people's limbs aren't the size of an orange, we hope not. But then you would have this held on, so there's nothing holding it on there. They also make these little fancy ones that are for fingers.
Oh.
So they're
Like
tubular
patterns?
dressings, so we can get them in all kinds of sizes and things. So like, think about people that get them on their fingers. Those would be a super
I would
good way
say
to not
and
tape
picking
around
on
them.
Too,
Yeah.
and picking on them and stuff.
Yeah, so there's all different kinds of this one. This one was super stretchy, and then there was a couple, I just kind of put a little bit of everything in your bag so you had everything to use. The other way you could hold it down without using tape is Coban. Only thing you have to be super careful with when you use Coban, do not get it too tight. But this will not rip their skin either. And it comes in all fancy colors. I don't know if we can get it yet, but I think our residents would like super colored stuff.
Isn't that kind of like vet wrap?
Yes, they use it for lots of vet wraps. I mean, you probably use it to hold dressing on dogs' limbs, on horses' limbs.
Super good stuff.
Yes, I love that stuff. And it's re-stickable, so you can pull it back, put it back on there. Just make sure that you're not pulling it as you wrap it around. You basically just want to wrap it around, not pull. Pull would cause too much pressure, and then you're going to end up with purple limb. Bad idea. So we'll get this cleaned up here, and then we'll finish right along. Anybody have any other questions?
I do. Would you use the Mepitel with other types of dressings?
You can. You could use an alginate if you needed to on top of it, but they probably suggest that you put it underneath it if you were going to use an alginate directly on the wound bed. But you could put that over to protect your flap, but we're going to be changing it. But you could use microbial dressings on top of it. So alginates might not be the best to use with it, but foam dressings would be pretty good. Also, like if we were going to use impregnated foams, like this one's, here's a Silvasorb sheet. This one could go on top of it. You could use the Inluxtra, which is kind of that foam conforming foam. So yeah, you could use stuff on top of it. They say that you can also use hydrogels underneath it and then place it on there.
Okay.
You can use creams, Silvadene, whatever types of creams are ordered, you can put those in it and then put the Mepitel over it. So that's a plus too. You know, it depends on how often they want it put in there. Finding it interesting, or am I super boring?
No, this is great. This is so helpful for us.
Well, I hope I don't just stand up here and tell you useless information, because that kind of defeats the purpose. My goal is always to teach you information you can use directly in the field. I don't want to just teach you pointless information. I want it to, because if you have an actual point of using it, you usually want to keep and retain the information I give you. Okay, so moving along. What in by selection, what should come next? We've learned how to diagnose, or not necessarily diagnose, we've learned how to assess them, we've learned how to treat them, what's next?
Prevent.
Yes, there you go. So, prevention, what can we do? So first, we should have an assessment when people come in, first initial assessment. Anytime after they have a skin injury, we should do a skin assessment. There's several different tools that we can use for this. The most widely used one is put together by a STAR program. I don't know exactly what the acronym is right off the top of my head, but it has the one that clearly states what's their nutritional status. It has to be a multidisciplinary approach. It isn't just nursing that prevents wounds. It's kitchen, making sure that we got proper nutrition. It's the dietitian, making sure that they're getting appropriate calories. It's the doc working with us to try and make sure that we got the best dressings, that we're doing everything, everything that we can to prevent it. Also, our aides are involved. Good skincare is absolutely essential. So what's involved with good skincare? We need to avoid harsh soaps. So I have tested the soap in the bathroom, and it's pretty acidic. Which, if you know what happens we want to be kind of in that neutral level. We don't want to be super alkaline, and we don't want to be super acidic. I think that the bathroom soap is a 3. So that could be the reason why most our residents have really dry skin to begin with, but we actually might be further drying it out and actually potentiating issues. So I'm really going to look into seeing what other kind of soaps we can get, and also what other cleansers we can get. Because if that might be okay for people that don't have any skin issues, but if they have a skin issue, do we really want to put them in that environment where we're actually causing more damage? No. So also we want to make sure we apply emollients to rehydrate and moisturize skin. We want to use barrier cream. If it's for incontinence, if they have continual moisture in any area, we would like to prevent that by providing a protective barrier before it actually breaks down. So, also, we can protect the skin with long sleeves, tubular dressings, protective devices. So, do they need shin guards? Do they need padding on their wheelchair arms? Do they need padding on the tables? what do we need to get them so that it's safer? We wanna provide that safe environment. So, interventions we can use, there's way more than this. These are just the ones I think that would be key to making sure that we have a good prevention program. So, provide a safe environment. We need adequate lighting. If they cannot see, we are likely to run into stuff. So, most tables aren't rounded. Most of them are actually cornered. So, that could be a problem. Pad the rails. So, we can pad those rails outside. Make sure that, things that they bump into are padded nicely. We also need to support their dangling limbs with either devices or pillows, because when they're just dangling around, they got the likelihood to bump into something. Usually, so that's why people that, self-propel themselves, when they're actually stationary sitting, maybe they should have wheelchair pedals that we put on while they're stationary sitting. Or maybe they've had a stroke and their arm dangles. You definitely would probably want to have something that holds their arm closer to their body so it's not likely to hit something along the way.
Not to name names, but Gary Loomis is one
Yeah.
fellow you really gotta watch.
Yeah, you definitely gotta watch for dangling, because when they have a weakened side, those are likely gonna be just kinda hanging out in the wind.
And you don't know it.
And he doesn't know it because he can't feel it, and it's decreased sensitivity, also gonna be an area that doesn't heal super well, because it doesn't have the, right blood supply, right airflow, things like that. So if we could prevent the injury from it happening to that, already decreased limb area, that would be better off for him. So, nutrition and hydration. We need to make sure that the dietary consults. The other thing is when you have a wound, you should always have speech in there, because cognition is definitely a thing. We should offer fluids between meals. You should offer fluids every time you see somebody. These people do not like to drink fluids. Why? They do not want to go to the bathroom, because they don't want you to help them. But we need to make sure that we reassure them that we will help them go to the bathroom, that it is necessary to promote health for them to drink more fluids. Decreases UTIs, decreases, impaired skin healing. Lots of reasons why people need to be hydrated. We as nurses are the worst people for that, because how often do we run a 12-hour shift with one drink? Lots. So we just really need to get on board with making sure that our staff is educated in that everybody needs to be hydrated, us and our residents included. Responsible bathing. So we need to try and use soapless products. We don't have any that we're using right now, but I'll kind of try to look into them now that I know what the acidity of the soap is. pH balanced soaps. So we need to, if it costs a few more pennies now to get a soap that might help it prevent it in the beginning, it is probably worth its weight in gold. Also, you got emollient type soaps that, hold the moisture in there. That's what emollient soaps are. They're going to retain the moisture that they currently have and help distribute it, rather than it just wasting off. Also, we want to pat dry the skin. So how often do you get in the shower? You get out and you rub it around, you're ripping the skin off. Those little layers of skin are coming off. So we want to make sure we pat them dry. Also, when they're slightly moist in the shower, after you pat dry their skin, that's when you want to put lotion on them, because it will retain the moisture from the shower, and you're already in the shower room, it's nice and moist. We want them to suck all that water in there. The other thing is, moisturizer is something that should be done on residents daily, and it should be done twice a day. Everybody needs moisturizer. Their skin is old. What is the #1 common factor for skin tears? Old skin. So we really want to make sure it's, as moist and hydrated as possible. So moisturizing the skin, we have a choice. Choose an appropriate moisturizer. What kind of thing are we trying to do? So you have humectants, which are the retention of moisture. Usually it's like an oil-based type moisturizer. Then you have an occlusive layer, which is definitely oil-based. Adds a layer of protection. So this one's most often like Baza cream. It's a protective layer that we're putting on. And then you have emollients, which is going to be like Eucerin or Cetaphil or, those really good Lubriderm. We want to pay the extra money for the better product, because if we use a better product routinely and we avoid skin tears, we're actually going to save them lots of money. What's 30 cents base? So you got 30 cents extra for this, better lotion, or you got, $40-some for each skin tear you cause. I don't know exact what it costs. I mean, I tried to look into it, but I didn't have anybody as a good example for right now. But the next one we have, I'll try and see how much it actually costs us in monetary value. Because I think monetary value really translates well with people in, what it's going to cost. So if we can prevent that, it might cost us $1 to prevent it. It's going to cost us $86 to treat it. So, grand scheme of things, I'd rather pay the $1 extra now. So then, other thing, education. Education is a must in everything in healthcare. Just because you've learned it once doesn't mean you remember it. So we're gonna have to go over it again and again and again. We've got to remind our aides. You know, some of them just don't know. And if they don't know, we can't expect, you know, high expectations from them. Once they know, you can expect higher from them. And you want everybody to do their best. You know, our goal is to promote the best for people and make sure that we're always living up to the potential that we have. So education always, always, always. So now we're going to figure out what the effects of friction are on dry skin. So each of you have, Holly doesn't have any because she's going to be the one that tells you when you put no moisturizer on. So what I want you to do is take your onion. This is going to be like skin layers, and I want you to take your lotion. So the reason why you all have a different lotion is because I wanted to kind of see which one's better. So what I want you to do is take some of our lotion and rub it all over your onion and stick it in your sock. Yep, yours just goes in the sock.
I was like, I should do something. That's a good idea.
Mine's smelly.
Can you toss the glove, right?
Oh, you get.
So make sure you moisturize it really well.
You know, and speaking of body care, water softeners, if they're not up to snuff, is that excess salt hard on your system?
The excess salt on your skin could be. And the other thing with Moscow area is we have lots of hot water or hard water, which could, you know, add mineral deposits. Again, why your cleansers are really supposed to be, you know, pH balanced and good for your skin, because we want to get all that residue away. Okay, so once you're all lubed up, go ahead and put it in your sock. Isn't that not good lotion? But I think it's from the dollar store.
Onion in the sock.
Okay, so once everybody's got it in there, let me know what you got.
That's like.
Oh, look at that good. Does that have to go to the bottom of the sock?
No, not necessarily. I think overuses we're gonna push some of it off. What I'd really like to see is how much skin Holly loses when she pulls it back out.
There's already a lot.
I wanna see what you got. Let's see what you got. Okay, Holly, show us what you got. And remember, they were all good onions, all nicely done. So she has definitely caused lots of skin tearing to hers. What do you got, Stan? Oh, not too bad for
He was careful.
kind of cheap lotion. I mean, but you see how most of it's still pretty intact? We could probably lay these back down. Hers is completely removed. It is now gonna, and it's still super crunchy. His is still kind of pliable and we can move it, not super crunchy.
There's a lot
See
in the
there.
sock.
And there's definitely hot in the
Water
sock.
sock.
How'd yours work out?
So you ain't dealing with the whole sock.
He's doing it carefully.
I couldn't find any super good lotion, so all of ours is kind of mediocre lotion. Yours did pretty good.
Yeah, this is.
There's a little, I mean, that was our remedy cream, so that's not too bad.
Yeah.
I mean, at least the skin's intact if we.
Yeah, it mostly stayed down.
So yeah, what this onion is supposed to actually represent is kind of the layers of dry skin on your body. And if you're putting lotion on, how'd yours do? Yours didn't do super bad.
Lost some into the sock.
Not too bad. So this one was the moisture barrier cream, so the protection that we use for incontinence. So it didn't do too bad. You still got quite a bit of protective layer. How'd yours do? Yours is that nasty smelling kind.
Yes.
I know. Ooh,
Uh-oh.
not too terrible bad. I mean, but as far as all the layers,
At least they stuck.
it's stuck together.
Yeah.
I mean, mine is gonna go bad because the first layer come right off. And
So that's cheap.
cheap. This is super cheap lotion. See?
Yeah.
You got it.
Okay, so that's kind of demonstrates what friction rubbing can do with super dry skin. Skin is going to come off. Hence, if we were to put moisture on this twice a day, if we had done it twice a day and it wasn't already super dry, we would easily pull it in and out of that sock.
Clothing has a lot to do with that too, wouldn't it?
Yeah, because you want to make sure, well, think about it, when they're putting their socks on, when they're putting their head hose on, when they're putting anything on, if their skin is dry and your clothing's kind of tight, it's definitely gonna pull. that friction and rubbing is definitely gonna pull off. The other thing is how many times do they go up and down? How often is some body part rubbing against something? Maybe they're a little bit bigger and their wheelchair's not as big. You know, they might be
Especially with
rubbing on the sides
females,
here.
You know, with the bra and stuff like
Yeah,
that.
excess moisture in that area.
Yeah.
So maybe we wouldn't have to use that kind of stuff there. Okay, so now we're up to, in your packet, what you're gonna do is at the very end, there is going to be this 10-question quiz. You go ahead and fill that out for me. And just so you know, both groups get 3, because you can pick the appropriate dressing, the appropriate type, and you guys work super well together. So I have no qualms that I think you guys are gonna pass superbly. And then before you leave today, I don't care if you drop this in my box, but if you could evaluate my class for me, that would be swell. Also, I kinda wanna know what you guys want me to teach you next time. Any other ending questions or things that you need to know? Well, thank you very much for coming.
Thank you.
Yay.
Oh, it's in the back of the PowerPoint one. Yeah.
Do you know what button we're supposed to press? I turned it and then, I don't want to turn it off because I don't know if that stops it. Sorry, that was a shot of Definitely hope she can edit.
I don't know. Whoever, like, I want to do something wrong and have
You
it,
want me to
like,
call her?
yeah.
Just call her. She's probably not downstairs though.
No.
I'd be like, you successfully defeated it.
I don't know how to shut it off. I don't know how to shut it off. Well, if Jennifer said to come, I have it still playing. She said she would edit out whatever we need to. I just don't, I don't know if I hit stop, does it have it? Because that would be bad if it doesn't.
Oh yeah, it won't erase it.
Oh yeah, I think it's pretty well there. I hope so. Did you learn anything new, Sam?